This lesson is about atrial rhythms. Until now, we've talked about sinus rhythm, which comes from the SA node. Sinus rhythm has a P wave, a QRS, a T wave, and it paces in a regular pattern. Now we're going to talk about rhythms that originate from other locations. Electrical impulses that originate from other locations are referred to as ectopy, if it does not come from the SA node. Right now we're going to talk about PACs, premature atrial contractions. I'm just going to draw a star over here representing a location that a PAC occurs. So you're in normal sinus rhythm, the SA node is causing atrial depolarization like normal, and then all of a sudden, this PAC occurs, and it depolarizes the atria from a completely different location. So what that does is it interrupts normal sinus rhythm. So you have an early P wave in QRS. Also, the leads that are watching this occur, they draw what they see. So when those electrical impulses move from one side of the heart across the tissue to the other side, it draws that picture. Well, when that point of origin changes from the SA node to another location, that electrical impulse takes a different path across that tissue. And so those electrodes see that, and they draw a different picture. So you might see maybe a peaked P wave. Could be round, peaked, notched. It might be round like that, peaked. It could be notched. It could be maybe biphasic, where it goes above and below the asymmetric line. It could be inverted. There's a number of scenarios that can happen, but the morphology of the P waves for PACs, you would expect them to be slightly different than that of the normal SA node P waves. So from there, the electrical impulse travels down through the AV node, down through the bundle of His, down through the bundle branches, and depolarizes the ventricles in the same way that the SA node does. So the rest of it is the same. The QRS looks the same as all the other QRSs. It's just the morphology of the P wave is slightly different, and it's early. So you have usually a narrow QRS, with the exception of, if the patient has a bundle branch block, but then you would still see that in all the other sinus beats. So the PAC QRS should look the same as all the other sinus QRSs. When this happens, the electrical impulse that travels across the atria also depolarizes the SA node. And what that does is it changes the atrial timing of the SA node. So it resets it. And that's what, when you say non-compensatory pause, that's what that means, is that the next sinus P wave that you would expect to fall maybe here, since it was reset here, well, the next P wave will probably start a little bit earlier. Atrial bigeminy. Atrial bigeminy is every other beat is a PAC. And that looks something like this. So you have sinus beat that occurs, and then you have a PAC. And then you have a sinus beat that occurs, and you have a PAC. And you have a sinus beat, and a PAC. So every other beat is a PAC. That's atrial bigeminy. Has a very, very distinct pattern to it. Now you can also have blocked PACs or non-conducted PACs. And what that looks like, you've got your sinus rhythm, and then you have a PAC, but in this scenario, that PAC is blocked through the AV node. The AV node has the ability to block impulses. And what happens then is you have a P wave and you have no QRS. So an early P wave with a different morphology than that of the SA node with no QRS would be a blocked PAC or non-conducted PAC. Here's an example strip of a PAC. It's hard to see the P waves in this rhythm strip, but you can see a little bit. You can see them a little more clearly in the bottom lead. But what happens is you have this very regular sinus rhythm, and then this early beat. And if you look at the early beat, that P wave looks much different than anything else you've seen than all these P waves do. It's upright and peaked, so it has a different morphology. It's early. QRS is still narrow. It's a PAC. Wandering atrial pacemaker. Wandering atrial pacemaker is when you have 3 or more different shapes of P waves. So how does this happen? Well, we've got the SA node, right? That produces a specific shape when the patient's in sinus rhythm. We'll just say those are upright and rounded. Now we're going to add our PAC that we talked about that depolarizes the atria from a different location. So maybe that has its own shape. Okay. They might have a sinus beat in here. And let's add a third one now. So a different location that is causing electrical impulse to occur. And it depolarizes the atria from in a different way than the others. So it might be slightly inverted, maybe. So now you have 3 different morphologies of P waves. You have from the sinus node, you have PAC number 1, you have PAC number 2. So 3 different shapes of P waves indicating 3 different locations in the atria that are causing atrial depolarization. Now when this happens, you have all these different pacemakers happening, all these different places in the atria that are pacing the heart. You can imagine if all those are going on at the same time, that's going to produce a pretty irregular R to R rhythm. Now you still expect to have a 1-to-1 ratio, right? 1 P wave for every 1 QRS. You'd expect that to happen. But just you'll see 3 different shapes of P waves. Multifocal atrial tachycardia, or MAT, it's the same thing. You have 3 different shapes of P waves, only the heart rate is greater than 100 beats per minute. And here's an example of wandering atrial pacemaker, commonly referred to as WAP. Here's their sinus rhythm P waves. And I know I'm saying they're sinus rhythm P waves because it's their norm. It's, that's what they're in most of the time. But then you have this early beat up here with what looks like an inverted P wave. So that's one shape. And then you have more sinus rhythm P waves until you get over here, and then you see another early beat with yet a different shape. So we have 1, 2, 3 different shapes of P waves, indicating wandering atrial pacemaker. Atrial fibrillation. This is when you have a very rapid atrial rhythm. Usually in textbooks, you'll read the atrial rate is greater than 350, maybe even greater than 400 in some books, or some books might even say it's not measurable. Its atrial rate is 0. You might read that too. What's happening is the atria is depolarizing very rapidly. You have some cells that are just depolarizing over and over and over again, and it's just random chaotic activity. And it does not produce a P wave. There's no P waves. Instead, you have this fibrillating baseline. And it looks something like this. And it could be really coarse, like this, or it could be very fine AFib, too. So you have all these impulses that are depolarizing the atria at, we'll just say 400 beats a minute. Now in sinus rhythm, when the SI node's pacing the heart, you have one P wave for every one QRS, right? So 1-to-1 ratio. So if your atrial rate in sinus rhythm is 75 beats per minute, your ventricular rate will also be 75 beats per minute. And when I say ventricular rate, I mean your R to Rs. Now, in atrial fibrillation, if your atrial rate is, say, 400 beats a minute, what's your ventricular rate going to be? Because if the answer is 400 beats a minute, you can't live on that. That would be fatal. Fortunately, the AV node right here acts like a surge protector. It is the gateway to the ventricles. Those impulses, they can't travel down this way. They can't do that because there's this, like a lining here that prevents that the conduction in that way. The only way that those impulses can get down to the ventricles is through the AV node. So it's like a gatekeeper. And what happens is that AV node blocks out a lot of those electrical impulses from reaching the ventricles. And it prevents atrial fibrillation from being a fatal condition, because without the AV node blocking a lot of those impulses, anyone that went into atrial fibrillation would also go into ventricular fibrillation, and you can't survive that. Now, from that point on, once the AV node allows those impulses through there, it travels down the bundle of His, down the bundle branches, depolarizing the ventricles, and it produces a relatively narrow QRS. But at what rate? Since it's not going to be 400 beats a minute, and what's the heart rate going to be? Well, it just depends. It depends on what the AV node allows through there. The AV node allows those impulses through in a very irregular way because the point of origin is irregular. It's chaotic. And so the AV node allows through impulses, but it's just in an irregular way. So you've got this very irregular heart rhythm in atrial fibrillation. Now, what rate's that going to happen? Well, we don't say tachycardic or bradycardic when it comes to atrial fibrillation. Instead, we say what the ventricular response is. So RVR means a rapid ventricular response. So if the heart rate is greater than 100 beats per minute, we say that they're in atrial fibrillation with RVR. They're having a rapid ventricular response. If the heart rate is controlled between 60 and 100 beats a minute, we say they're having a controlled ventricular response. And SVR is if they're having a slow ventricular response, so less than 60 beats per minute. Usually when people go into AFib, a lot of times their heart rate goes up. They might have a controlled or rapid ventricular response. Sometimes their heart rate actually goes down, so it's possible your patient could go into atrial fibrillation, and if the AV node blocks out a lot of those impulses, then their heart rate could actually go down a little bit. Here's a strip with AFib. You can see this really chaotic, coarse baseline. The R to Rs are very irregular. And here, the QRS, it looks a little bit wide, but if the patient has a bundle branch block or some type of conduction delay through those bundle branches, you're going to see a slightly wider QRS. Atrial flutter. Atrial flutter is another rapid atrial arrhythmia characterized by an atrial rate of 250 to 350 beats per minute. So a little slower than that of AFib. And the mechanism is also a little bit different. You've got an atrial flutter, you have this reentry mechanism that forms. And what it does is it depolarizes the atria in this loop over and over and over and over again. And those impulses, some of them make it through the AV node and reach the ventricles. But that continuous loop reentry that forms produces this very regular sawtooth pattern. Like that. Very distinctive. And again, you don't have any P waves. We just call these flutter waves that form a sawtooth baseline. And the R to Rs, the rhythm, can be regular or irregular. Because this reentry pattern is regular, it could produce a regular R to R interval, or it can be irregular. It just depends on what the AV node allows through there. So you could have an irregular pattern that is like this, where here you have a 1-to-1 AV conduction. Here's 2-to-1 AV conduction, right? So there's 2 flutter waves for 1 QRS. Here's another 2-to-1. And then these are just 1-to-1. So it can be irregular. It can also be a regular pattern. Let's redraw the flutter. And it can be, you could have 1 QRS maybe every other. So consistent 2-to-1 AV conduction. And this can be confusing for some people because when they're looking at a continuous 2-to-1 AV conduction like this, they sometimes look at this and they think that this is a T wave and this is a P wave, and they think that the patient's just in sinus rhythm or sinus tachycardia. But if you look, you should be able to identify this flutter pattern that marches through there. So just be aware of that. And if you suspect that it's atrial flutter, then you should look at some of their rhythm strip, their history, and see if you can see any breaks or patterns or breaks in the rhythm that you can see this clearly, like if you were able to see a break in that pattern, in that 2-to-1 AV conduction, where you could identify clearly this flutter pattern. And you'd want to save a strip to show that. And here's a strip with atrial flutter. You can see this very distinct flutter pattern that marches through here. It's very regular. And this is, you have some that are, like this is a pretty regular section here, atrial flutter. It looks like a continuous 4-to-1 AV conduction, but then it starts to break up. It gets more irregular over here. So atrial flutter can be regular or irregular. And if we're applying our knowledge we learned as far as how to calculate rate, if I see one large box between flutter waves, we can use our 300 method to calculate how fast that is. Well, 300 divided by 1, because there's one large box between flutter waves, well, that of course equals 300. So the atrial rate is 300 beats per minute. Atrial tachycardia. This is like atrial flutter. There's a reentry that occurs. However, it's at a slower rate, 150 to 250. Now we said that the AV node blocks out a lot of those impulses because you don't want your heart rate to be 400 beats per minute. You don't want your heart rate to be even 300 beats per minute. That's just too fast. 250, still too fast. But atrial tachycardia starts at 150 to 250. So at what point is the AV node going to start blocking these impulses? Because if I got up and started running, I might be able to reach 150 in sinus tachycardia. So at what point is the AV node going to start blocking those impulses out? It could be around 200. It just depends on the individual. But what this is going to produce, instead of that very regular sawtooth pattern, it's going to be slower. So still kind of a sawtooth pattern, but it's slower. And you don't see this quite as much as you do atrial flutter, atrial fibrillation. And when the atrial rate slows down, it gets confusing because people aren't always sure what to call it. This, of course, you can have, if it's closer towards this 250 mark, you would expect to see more blocking through the AV node. So you might have 2-to-1 AV conduction. Maybe this one got blocked here, and this one got blocked. But you could also have each one of those conducted through the AV node. If it's closer to that 150 mark, the AV node might not block those out. So how would I tell the difference between this and sinus tachycardia? Well, that might be more difficult. In this example strip, it's a little clearer to see because you can see breaks in the rhythm. Here, with the green arrows, you can see these are the P waves. This patient's in sinus. And then all of a sudden, it gets irregular. And you see these little like flutter waves that kind of persist through this rhythm. Well, because that atrial rhythm of atrial tachycardia is a reentry, it has a regular pattern to it, like that. So I can see one here and one here, and I have one here. So I would also have to assume there's one in here as well, and then one in here as well. So if you took calipers and you map that out, you would expect those to map through there. And then it stops, that reentry pattern stops, and the patient goes back into sinus rhythm. But what if there aren't breaks in it? If there are no breaks in it, you can't maybe tell how fast the atrial rate is or what's happening. So what do you do at that point? Well, that brings us to supraventricular tachycardia. Supra means above the ventricles, tachycardia. So we're talking about rhythms that originate above this line. And what we're really saying when we say SVT, by using this in a broad sense, we're saying that it could be any arrhythmia that comes from above the ventricles, which is a number of things. Now, why would we use this term? Well, sometimes rhythms are very rapid and fast, and it's hard to tell for sure what is happening, what rhythm that is. So, textbook definition is greater than 100 beats per minute. You'd expect the R to Rs to be regular, QRSs to be relatively narrow. Well, why would they be narrow? Well, any arrhythmia that occurs in the atria travels down through the bundle of His, down the bundle branches, and depolarizes the ventricles in a normal way, in producing a narrow QRS complex. So that's one of our definitions for SVT, is that the QRS is expected to be narrow. or relatively narrow by comparison to all the other sinus QRSs that the patient has. So just an example of how you would use the term SVT. If you had a patient that was just put on a heart monitor and the rhythm that you saw looked like this, and it was maybe 170 beats per minute, well, you see how fast that is, and you can't look in here and see any P waves for sure because it's so fast. When rhythms get really fast like that, if there is a P wave, it often is eclipsed by the T wave, so it's hard to see. And if this patient's rhythm persisted at 170 beats per minute for a half hour or an hour, you might not be able to tell if they're in sinus tachycardia or atrial flutter or junctional tach. We haven't talked about junctional tachycardia yet, but you might not be able to tell what rhythm the patient's in because of the rate, how fast it is. But you would expect it to be regular, because if it was very rapid and irregular, well, then you might expect it to be atrial fibrillation. So why would we include atrial fibrillation in that list of possible SVT causes? Well, atrial fibrillation, it gives itself away based on its irregularity. However, when atrial fibrillation is incredibly fast, maybe 200 beats per minute, it can be very difficult to tell if it's AFib or not, because when it gets really fast, it also looks more regular. And if it happens in a short little episode, a little burst of 5-6 beats, you might not be able to tell if it's atrial fibrillation or not. Now, using the term SVT, it can be used broadly in classifying any atrial arrhythmia, or it can be used very narrowly in specifically talking about reentry mechanism tachycardias. But basically, using the broad definition, you're saying that it's rapid, it's regular, the QRSs are narrow, and I'm not really sure what's causing it. So it's a way of saying I'm not sure, but it's not ventricular tachycardia. So here's some example strips of, the first one is how SVT would start. As you can see, the patient, and it's hard to see their P waves, but this patient's in sinus rhythm up until here. And their rhythm, you can see it's regular, and then all of a sudden, it gets really fast. Suddenly. It's not gradual. It's not like they got up and started walking and running and their heart rate gradually increased. This is a very sudden onset of tachycardia. And we call that paroxysmal. When it starts suddenly like that, it's paroxysmal, or you could say paroxysmal supraventricular tachycardia, or PSVT. And that's being more specific. You're saying you saw the onset. If I say it's PSVT, I'm saying that I saw the onset, it started paroxysmally, and you're more specific, so you can kind of exclude things like sinus tach. Sinus tach doesn't start suddenly like that. It's more of a gradual increase. So you're being more specific. Now these QRSs, you can see they all look just like the patient's normal sinus QRSs. And that's why I'm saying this is SVT, supraventricular, because if it were ventricular tachycardia, which we'll learn about later, those QRSs would be much wider. But when they're narrow like that, narrow like the sinus rhythm QRSs, we can assume it came from above the ventricles. But I don't know exactly what caused this to happen. So that's why I'm being vague, and I'm saying supraventricular tachycardia. It just came from up above the ventricles. I'm not sure why or how exactly. Now the bottom strip, that is something that you'll see. It's a short duration. It's you have the sinus rhythm here, and then you have this paroxysmal SVT and it's rapid. We don't know exactly what caused it or why. But then it stops suddenly. So it starts paroxysmally, it stops paroxysmally. And you might label this as 1, 2, 3, 4, 5 beats of SVT at whatever rate that it is, approximately 150. Looks like a little bit faster than 150, but pretty close to that. But again, we don't know exactly what caused it for sure. And that's what we're saying when we call it SVT. And that concludes atrial rhythms.